You can click on Start Webinar.
We're ready.
Have you spotlighted 7 presidents? And then bring down the poster.
Elizabeth.
Okay, Linda, you're on.
Okay, we are ready to begin. Welcome, everyone. Welcome, whether it is good morning, good afternoon, good evening. It's my pleasure to introduce you to the Bloodless Medicine and Surgery Week conference on Thursday, May 15th. I am Linda Shore-Lesserson. I'm currently the president of SABM, the Society for the Advancement of Patient Blood Management, and it is my honor to be here presenting and sharing and supporting this conference as a participant of SABM, which is wholly supportive of this conference. Now, May is Bloodless Medicine and Surgery Awareness Month. The Bloodless Medicine and Surgery Awareness Week in the month of May is intended to raise the awareness of bloodless medicine and the superiority of bloodless medicine as a form of healthcare. It's organized by the Bloodless Medicine and Surgery Group in the University of Calabar in Nigeria, in collaboration with the Bloodless Medicine and Surgery Society, as we all know, the BMSS. This conference is supported in conjunction with the BMSS by the Society for the Advancement of Patient Blood Management, SABM, and the Malaysian Society of Patient Blood Management, MyPBM. The theme of this year's May conference is Bloodless Care in Orthopedics and Trauma. So it's now my privilege to introduce my co-moderator of this session, Dr. David Jadwin. Dr. Jadwin is a pathologist, and he is professor and the originator of a healthcare company called Columbia Healthcare Analytics. He's been a passionate advocate of careful and rational blood utilization and of bloodless medicine. And now I'll let Dr. Jadwin continue with the rest of this morning's program.
Yes, thank you, Linda. My name is Dave Jadwin. I'm pleased to be a co-moderator today. Just have a few housekeeping rules. The first is please mute your microphones and submit questions through the Q&A section, but please indicate the physician to whom you want to address the question or your question. And please minimize the chat with other participants so as not to distract other attendees and the speaker. The program is being streamed live on the BMSS YouTube channel in case you're having difficulty with the Zoom. And you just have to type in Bloodless Medicine and Surgery Society in the YouTube section. Our first speaker today is Dr. Pius Agui, who is a consultant orthopedic surgeon and the head of the Orthopaedics and Trauma division at the University of Calabar Teaching Hospital in Nigeria. His topic today is bloodless total knee replacement in a low resource setting. Dr. Agui is the immediate past president of the Accident and Emergency Department at the University of Calabar Teaching Hospital, a position he held for 3 years before becoming head of the Orthopedics and Trauma section. Dr. Agui earned his bachelor's degree in medicine and surgery and pursued specialization in orthopedic and traumatology after earning his fellowship of the West African College of Surgeons. He further developed skills in arthroplasty and spine surgery, and at UCTH collaborates with fellow specialists to enhance arthroplasty, patient care, and surgical outcomes. Beyond his clinical responsibilities, Dr. Agui is deeply invested in medical education as a lecturer in the University of Calabar. As a dedicated teacher with a holistic approach to medicine, he mentors medical students and develops orthopedic surgeons as the next generation of healthcare professionals. As a visiting surgeon to rural Nigerian hospitals, Dr. Agui makes a broad contribution to regional healthcare. I'd like to welcome Dr. Agui at this time. Thank you.
Thank you very much. And it's good to be here. And I say good morning, good evening, and afternoon to everyone from wherever you're listening to me from. I'm here to talk about bloodless total knee replacement in a low resource setting. So I would begin with telling all of us that I have no disclosures. There's no one sponsoring this presentation. This is just to highlight to us that we're in the Bloodless Medicine and Surgery Awareness Month, like has been stated. This is where I begin. Now, the practice of bloodless total knee replacement surgery in low resource settings can be quite challenging because of...
Sorry, Dr. Agui, I don't think you're sharing your slides.
Okay. Let me go back. But can you see me?
Yep. Schneider, can you see him?
Yes, we see you. Yes.
Okay, let me go
Yes.
back and... I'm on slideshow.
No, click on share. Share in the middle of your Zoom screen. You have to go to the Zoom screen.
One moment, let me exit the...
You don't, not sure you need to
Oh.
exit. You just...
Okay, so share. Can we see that?
Yes. We see it, but not in presenter mode yet.
So I'll go to
Perfect.
beginning.
I'm Dr. Agui, I'm sharing my screen. You can just tell me next slide.
Okay, so are we happy with this now?
Yes.
It
Perfect.
looks... Schneider, are you the one that shared the slides?
Yes. Yes, I'm the one that's sharing.
Okay,
Okay,
try advancing. Schneider, try advancing. Let's see. Oh, you did. Okay. All right. So you can go back to the topic now. Sorry, Dr. Agui, it looks like Schneider decided to help you.
Okay, so but can I still move the slides myself?
I don't think it's possible. Schneider,
No.
do you want him to try? Do you want him to try sharing his own slides first?
Okay, I can stop sharing.
Okay.
So I had started sharing already.
Try again now.
I had started sharing, but let me do that again. So this is share, and
Select the PowerPoint window.
okay. Is it working?
Yes, just go to slideshow.
It says your screen is sharing, right?
Yes, but
Go
just go to
ahead and click on
slideshow. The top middle. Yep, click on slideshow. To the right, to the right, to the right.
He wants to use the one he normally uses.
Okay.
This is slideshow here.
Click it. Let's see what will happen.
There
Okay,
it goes.
that works.
So we're good to go.
Yes.
Yes, you're okay.
That's great.
Okay, so I'll just quickly go back. This is the topic. I have no disclosures. This is Bloodless Medicine and Surgery Awareness Week, and it's been going on months rather, and it's been going from the 1st of May. So this is a bit of an abstract. The practice of total knee replacement surgery in low resource settings like ours is usually fraught with challenges, and there are a myriad of these challenges, which would include limited surgical expertise across board. By this, I mean from surgeons, especially surgeons in arthroplasty, to even the nursing staff and anesthetists who are specialized in this area of medicine. Then we have patient-related issues like belief systems from patients and ignorance. Poverty also is some of the reasons why we don't even get to see as many patients as we would love to see, and then they tend to wait to raise funds to come see us. I'll be using a 73-year-old female patient whom I did left total knee replacement surgery for as an illustration, for illustration purposes. For her case, we deployed multimodal blood conservation to highlight further. She also had some post-operative blood loss because there was drainage. However, she had full recovery and didn't require blood transfusion. Like I said, the substantial blood loss associated with total knee in low resource settings for the reasons I earlier mentioned, late presentation, so you have more complicated surgeries to do, which would add to surgery time, and with length increase in surgery time would come increase in blood loss as well. Then they may also be anemic, which would be an associated comorbidity, but because it's an elective procedure, you have time to walk up the patient and build the patient's hemoglobin level. The strategies we use is typically based on the pillars of bloodless medicine and surgery. Now, the case I'm using as an illustration just highlights how successful implementation of these bloodless care techniques enabled us to do a bloodless total knee replacement surgery on the left knee of this patient while we are waiting for her to rebuild before we do the right knee. Like I said, it was a bilateral severe osteoarthritis of the knee. Just a brief look at the she's 73 years old. JW had bilateral knee pain for about 10 years. This also buttresses the fact that they tend to come late. I mean, going on for 10 years, she was at the point of barely being able to walk before she presented. She had a comorbidity of diabetes, and then she had truncal obesity. Of course, there was mild anemia because her packed cell volume was 32%. So this was our diagnosis, severe bilateral osteoarthritis. She declined acute isovolemic hemodilution, and so we had to deploy other modalities. I just thought we should look at the knee and talk about it a little, buttressing how late she presented. The left knee is here displayed on this radiograph. You could see the medial tibial condyle completely eroded, which typifies how bad they can present to us and how late they can present to us. The patellofemoral joint space is completely absent in the lateral image you can see here. There's no joint space. The osteophytes everywhere, completely obliterating the joint space. Just quickly to add to what we found in examination, tibial torsion, extension lag of about 10 degrees, lateral tibial thrust when she walks, which depicted lateral collateral ligament laxity. The distance between the medial condyles of the knees was 26 centimeters, and a varus angle of 35 degrees, especially when she stands, when she's bearing weight, this degree even worsens. Now, what is the objective? I'm here to describe the preoperative, intraoperative, and postoperative management of bloodless total knee replacements, and highlight challenges of surgeons that we surgeons in this in low resource settings face when we have to do this kind of procedures. And then also highlight blood conservation strategies we have to deploy in low resource settings like ours. Now, this was done in University of Calabar Teaching Hospital. I'd also discuss challenges and considerations, and then the focus is on practical, accessible methods to manage blood loss effectively. I know a lot has been said about the rationale for bloodless surgery in general. So this is just to look at it very briefly. I don't have to elaborate on this any further because most of the presentations have taken care of this. But it's important to note some of these risks, which would include associated risk of blood transfusions like immunological reactions, infection transmission. There are also other risks associated with being in a low resource setting in particular where screening processes may not be very reliable, and then subpar storage conditions for this blood. It's also pretty expensive to run a blood bank, and then also patients have to buy blood most times, and this would cost money. Now, bloodless medicine and surgery is just a quick look at what bloodless medicine and surgery entails. It's the provision of quality health care without the use of allogenic blood transfusion, with the aim of improving clinical outcome and protecting the patient's rights. Those are my authors. Then this tells us about blood patient management, which is tailored towards the patient himself or herself. It's a patient-centered, systematic, evidence-based approach to improve patients' outcome by managing and preserving a patient's own blood while promoting safety and empowerment. Now, these are the pillars of bloodless medicine and surgery. It's nice to keep going over this again. I know we've seen them before, but yes, so that it is reinforced. And so the pillars of bloodless medicine and surgery would include optimizing the hematocrit of this patient, minimizing blood loss, and then optimizing tissue oxygenation, and supporting physiological tolerance to anemia. I had total knee replacement who post-operatively had hematocrit levels of 18%, and we were able to gradually build her up to adequate levels. Other than the index case, I mean. So we've had situations like that. These are the pillars of patient blood management. Similarly, you have optimizing the hematocrit, minimizing blood loss, and then supporting patients' tolerance to anemia. Now, in our preoperative planning, what do we do? In low resource settings, the principle is to, because, for instance, we are dealing with a total knee replacement here. So the plan is to first improve on the hematocrit level of this patient by giving common iron-rich foods, also giving iron itself, either oral or intravenously, and then giving vitamins to include vitamin B complex, folic acid where you can, but in patients who have any form of malignancy, you don't want to give that. And then we encourage them to eat their normal diet, but we also introduce a lot of green leafy vegetables, fish, and other sources of iron. Like I said, iron supplements, multivitamins. Then erythropoiesis stimulating agents. Commonly, we use erythropoietin in this part of the world. Of course, we would get an informed consent about blood conservation protocol from this patient. And then we would like to also discontinue antiplatelets and antithrombotics. These are agents that could worsen bleeding in the course of surgery. Profile for this patient. in preoperative planning also, in order to minimize blood loss, we also would like to do a thorough clinical evaluation of these patients to ensure that there are no bleeding disorders in these patients. Patients who have been on prolonged use of non-steroidal anti-inflammatory drugs, oftentimes because in low resource settings, these patients will present late. They would have presented to a lot of people, gone to patent medicine dealers, and commonly non-steroidal anti-inflammatory medications are given to these patients for very long periods. So by the time they come, the effects, the anticoagulant effect of these medications would be something we'd have to battle with. And then also find out the patients on anticoagulants, which we'd like to stop. And depending on the type, might be weeks before the surgery. Antiplatelet agents. Most patients, we all know in this part of the world, hypertension is high. And some of these patients are put on antiplatelets like clopidogrel. So you want to stop that as well. Some of these patients will have tried herbs, and some of them we don't know their effects. Some may have anticoagulant effect as well. And then, assess for pallor using the hematocrit, and then ensuring that we build up this patients. We sometimes would want to give tranexamic acid even ahead of the surgery, especially for patients who may have suffered from the effects of anticoagulants for long periods. And then vitamin K is also given. Epsilon aminocaproic acid is sometimes also given, factor 7 where available, desmopressin as well. And then we try to limit phlebotomy as much as possible to reduce losses from those areas. If there are any bleeding points also in these patients, you want to stop them as well. And then non-invasive monitoring where possible, but in low resource settings, again, that might be a challenge. For intraoperative management of these patients, the things we would like to do would include minimizing blood loss, which is the main goal. So intraoperatively, you want to limit bleeding as much as possible. So what are the things we like to do? Like I said, the approach was multimodal. We've talked about what we did preoperatively. What we usually do intraoperatively would include the things I'll highlight here. We tend to use tourniquets a lot in total knee replacement. In this part of the world, non-pneumatic tourniquets are still in use, even though the way to go is pneumatic tourniquets. Usually in low resource setting, for various reasons also, surgery time may be longer than usual. Regional anesthesia is helpful because you may be able to also create permissive hypotension with an experienced anesthetist. Tranexamic acid is widely used in this part of the world in various doses. For this patient, what I did was to give 1 gram bolus IV before surgery, and at surgery for every 500 mils of normal saline, which is a crystalloid, put in 500 milligrams of tranexamic acid. And then position of the patient. Typically, in total knee replacement, the position is supine. The knee is flexed for most of the surgery. That really helps with reducing blood loss. Now, for this patient, surgery time was a little over 2 hours, and so tourniquet had to be taken out at 2 hours. But knee flexion proved very helpful in limiting the blood loss in the course of the surgery. And then, of course, also meticulous hemostasis. Dieting was available. Surgical and bone wax not available, but yeah, dieting was also helpful in limiting blood loss. Other options intraoperatively would include, which I didn't deploy in this particular index patient, would be acute pneumovolemic hemodilution, cell salvage and reinfusion with pneumothemia being the way to go. So temperature of the patient is kept as warm as within the normal limits. The trend now is minimal access surgery. In total knee is not yet very popular, so that would not play a role here. I'd like to talk a bit about the use of tourniquets in total knee replacement surgeries. So we could have the automatic ones. The pneumatic tourniquets come as automatic or as manual.
No, I have it in the background. I'm not.
The manual ones, we tend to inflate. They're usually like the traditional blood sphygmomanometers. Basically, that's how they come. We deploy them and then clamp the tubing, whereas the automatic ones, self-inflatable, timed on their own, and then deflate at the appropriate time that has been set. Non-pneumatic tourniquets are still in use. We use S-match bandages quite a lot here, and then we have to physically time this to ensure that we can take down the tourniquets at the appropriate time. It's important to note that they have complications, especially the non-pneumatic, because you don't know the pressure you might be using. So yeah, and then patients who have comorbidities, there's some relative contraindications for using tourniquets in these patients. Here is a research work done in Nigeria where orthopedic surgeons were given a questionnaire to see the use of tourniquets generally, and the conclusion you would see here is that the non-pneumatic tourniquet was more commonly used than the pneumatic tourniquet, and application of tourniquet on sites other than the thigh and the upper arm were uncommon. So the most common places is usually the thigh, like I said. So we use tourniquets a lot in total knee replacement surgery, and that goes a long way to reduce blood loss in surgery for total knee replacement. The most common complication still remains neurological injury. So the idea is to, as much as possible, keep tourniquet, don't apply tourniquet for longer than 2 hours. I also wanted to touch on tranexamic acid use because it's been widely used and most commonly used in this part of the world as well. It's an antifibrinolytic agent that has been extensively studied for its efficacy in reducing blood loss in total knee replacement. Here is one of the studies, a systematic review and meta-analysis done by Schreider in 2011. And these demonstrated that tranexamic acid significantly reduced postoperative blood loss by an average of about 591 mils and decreased the proportion of patients requiring blood transfusion. Another study was done where 2 grams of tranexamic acid is put in 50 mils of, there's a correction there, please, of 50 mils of normal saline. Sorry, please, I'll correct that later. And that it was found to significantly reduce total blood loss by about 620 mils as against 1,094 mils in controls. And this didn't increase the risk of thromboembolic events. So, and notice that this was applied topically. So it's mixed in a syringe, it's drawn and splashed at the area we are operating. Another study in Malaysia reported that intra-articular injection of tranexamic acid resulted in significant reduction in postoperative hemoglobin drop. And there you have the values, which was quite statistically significant, and therefore it decreased the rates of transfusion. This is another study done in Nigeria, and it talks about the outcome of routes of tranexamic acid used in total knee replacement surgeries in Nigeria. What I'd like to highlight here is that the study, I'll go to the conclusion, the study highlights the importance of tranexamic acid administration routes in total knee surgery. They found that combined intravenous and intralesional, by intralesional we mean directly injected into the intra-articular space during surgery, that it showed superior efficacy in reducing blood loss and minimizing the need for postoperative transfusion. So this combination was found superior to just intravenous use of tranexamic acid. Now, what are the other intraoperative measures and what is the goal again? The goal again for intraoperative bloodless surgery management would include optimizing tissue oxygenation at all points. And so in the course, the anesthetist is actively involved in this. Where necessary, oxygen is administered to the patient and ventilation of this patient is appropriate. And then we ensure that volume replacement is done judiciously with crystalloids, especially where you have blood loss less than 25%. And we intend to introduce colloids when the blood loss is estimated to be above 25%. Opiate use is also minimized. Opiate use is also involved, and it tends to reduce the oxygen consumption required by this patient and prompt an appropriate treatment of sepsis where necessary. But these do not fall under intraoperative measures. The other intraoperative measures would include surgical efficiency and vigilance in the technique. So meticulous surgery, really important, ensuring that all vessels are isolated, ligated where necessary, or clamped and diatomy used as well. And then if surgery is efficient, of course, you would reduce operation time and thereby reduce bleeding time. In this patient, because it was a late presentation, surgery time was a little longer than expected. So we had to take down the tourniquet earlier than we should, because on the average, this surgery should be like 2 hours. It is important to realize that expertise of the entire operating team, particularly in low resource setting, can negatively impact efficiency and the synergy in theater, which in turn increases operation time. Now, I would like to highlight or talk about this a little more. So in situations where, for instance, the trained nurses are very few, arthroplasty nurses are and in resource limited settings, those are the things we're talking about. The surgeon's expertise, he's probably done maybe like maybe just 10 of these surgeries, and then his nurse hasn't assisted in main or hasn't undergone the proper training. This tends to slow down the surgery time, and this tends to increase surgery time actually. And the synergy between the surgeon and all the other members of the team can also militate against speedy surgery, which would give blood loss. Autologous blood salvage is also deployed where possible. Of course, in total knee replacement, there isn't quite any that I know of just yet, but I'm sure it's in the pipeline. This is costly and is also equipment dependent. So in a low resource setting, that might prove a problem as well. Now, post-operative care and post-operative course, the goal is to support patients' physiological tolerance to anemia. And then in the process, we are minimizing the blood loss, optimizing tissue oxygenation, and then also accelerate hematopoiesis. So post-operatively, you also want to give hematinics. You have done that preoperatively. Post-operatively, you want to do that as well to speed up hematopoiesis. We also monitor the outputs continuously. So drain site output monitoring is really of the essence here, and vis-a-vis the hemodynamic stability of this patient. So that's why the monitoring is important. Now, where possible, we would avoid the use of drains, and then apply compressive bandaging, and then deploy the use of ice as well. This tends to reduce blood loss post-operatively as well. However, like I stated here, caution needs to be applied because compressive bandaging could also lead to compartment syndrome. And imagine you had used a tourniquet, which increases that risk as well, and then you go on to do compressive bandaging for a total knee replacement case. So we have to be mindful of that possible complication. Opiate analgesics immediately post-op is also used, which tends to decrease, said to decrease oxygen demand in this patient. And then if there are any electrolyte imbalances as a result of massive blood loss, then these are corrected as well. Then as much as possible, patient is not mobilized too early until we improve on the hematocrit levels as much as possible. Now, this is variable. So the post-op hematocrit is usually measured, and then that determines what you do in terms of limiting the patient's activity post-operatively. In the index patient, this is what transpired. A drain was used. It was removed on the second day post-operatively. The total output was 550 mils, which wasn't too high. There was no post-operative transfusion, of course. Post-operative pack cell volume was 26%. This was done on the second day post-operatively as well. There were no signs of hemodynamic instability in this patient. However, the patient developed mild tourniquet palsy. That I might want to attribute to the fact that she's a diabetic, so she probably had vascular problems as well. So the added insult, so to speak, of a tourniquet probably was the reason why. I want to also buttress the importance of tranexamic acid by another study done in Nigeria, where Okwesili in 2019 in Nigeria reported a retrospective review of 86 total knee replacement patients using low-cost, high-impact techniques such as preoperative iron therapy, tranexamic acid, and restrictive transfusion thresholds. Their transfusion rates dropped by a significant margin from 35% to 8% over a 3-year period. Now, what are the challenges we face in low resource settings? Now, belief systems is quite a challenge. Most of the times our patients come to us after they have visited everybody else but the medical practitioner. By this, I mean they would have probably gone to a church, they would have talked to a neighbor who tells them, I had the same kind of problem, so this is what was done for me, or some herb was given to me. All of that time is wasted before they get to you. And what is their belief? They believe that if a knife comes to your skin, especially for, I mean, this is what I get to hear as an arthroplasty surgeon. They'll say you'd never walk again if you have an arthroplasty done to your knee. So that's the commonest belief that we have to undo in these patients by the time they get to us. Even when they're convinced that nothing else is going to work, it takes quite a while to be able to talk to them or talk them out of that belief. So they present late with complications, with more severe deformities associated with the primary pathology. They also come with mismanagement complications. Traditional bone setters and all kinds of people may have done all kinds of topical applications to the limb. And yeah, so they get to us finally when we are like the last resort, sadly. Abuse of non-steroidal inflammatory medications is quite common. Thing is, you have a lot of patent medicine dealers, so you don't have significant control over these medications as they're sold over the counter commonly. Malnourishment can also be another challenge in this patient. Then the other challenge again would be limited expertise. And then of course, these surgeries are not done as frequently as you would like, because in low resource settings as well, people are poor. They take time to raise this money. So sometimes it's not just about the belief, but having to raise the funds for expensive types of surgeries like this. Lack of equipment is also another factor. Access to medications, it's important to note that tranexamic acid, however commonplace, may not be universally available in certain very remote settings. In my profile, I hinted that I also practice in very rural settings. to deliver orthopedic services to places in remote places where you don't find orthopedic surgeons. Some of those areas, the closest orthopedic surgeon you may see would be about 300 kilometers from those kind of places. So when you get to these places, you sometimes don't find tranexamic acid, you don't find, of course, Surgicel is even far-fetched, talk less of bone wax. Even iron supplements may be difficult to find, except the very common ones. Yeah. The other challenge would include training and protocols. So developing protocols, but I'm in the University of Calabar Teaching Hospital. We have as our head Dr. Nathaniel Usoro, who's played a very huge role in ensuring that a protocol is developed and is followed through. And the Bloodless medicine and surgery team is usually engaged where absolutely necessary to deploy this protocol for us to institute management. However, yeah, I'm sure he'll be able to tell you that there was institutional inertia at the very beginning, but we've come a long way now. Then there are also economic constraints as well. Intraoperative cell salvage, for instance, cell salvage equipment, of course, can be very far-fetched in settings, low resource settings. The patient factor is also highlighted here, but here, the role I want to talk about, the part I want to highlight on would be comorbidities in this patient. So if they have that can pose an additional challenge, like this patient who had diabetes, and she also had anemia. Of course, anemia can be taken care of more easily, but diabetes with vascular pathologies and association played a role, and like I said, probably contributed to her developing the tourniquet palsy, even though it was within 2 hours. I like to note also that for her, it was actually an automated pneumatic tourniquet that was used, but in spite of that, she still developed tourniquet palsy. Outcome and feasibility. So complications from tourniquet use where you have to, this might also result in delayed mobilization. This patient, yes, mobilization was delayed. Parcel volume dropped only by 6% from 32 preoperatively to 26%. And overall, the functional recovery was satisfactory. And this has been reproduced so many times in our setting. Now, what are the highlights of bloodless total knee replacement strategies in a low resource setting? The important highlights would be pre-planning and preoperative preparation of these patients, which should be taken seriously, and a protocol duly followed. Combination of techniques should be deployed because actually there's no standalone alternative to blood transfusion. You cannot say it's just tranexamic acid I want to use, for instance, but where it is applicable, you don't need to deploy another strategy, why not? However, oftentimes we have to deploy a multimodal approach. Tourniquet and knee positioning for knee replacement is simple and reproducible. The knee positioning is primarily flexing the knee to as much as 150 degrees, and that would dramatically cut the blood flow to the OP site, operation site. Of course, like I said before, the use of tranexamic acid is quite cost effective. It is not too expensive in this part of the world. Individualization of the technique to suit specific patient requirements is important. So this is where patient blood management protocol comes into play. And like had been highlighted in the course of this presentation, a multidisciplinary approach is of the essence. So the anesthetist is actively involved, and the surgeon, his assistant, the scrub nurse as well. When all of these parties are engaged, the hematologist is also involved. Of course, the bloodless surgery unit team is also involved as well. So this tends to help with going ahead with these procedures without much challenges. There's also the emphasis should be on less reliance on sophisticated technology as much as possible, whilst Emphasis should be on the management team and patient education as well. If a patient is properly educated, we would have these situations we find in the low resource settings where they come late, they come anemic, and all of that. So this is my conclusion. Bloodless total knee replacement is achievable in moderate anemia, even in the elderly. It is also very achievable in this low resource setting, in spite of the challenges we would face. Conservative strategies can be effective even without advanced resources. Now, protocol should always be tailored so that we can improve the outcome while reducing the cost. Thank you. These are my references. Thank you all very much for listening. I want to particularly thank Dr. Nathaniel Usoro as well. He's played a huge role in developing bloodless medicine and surgery in the University of Calabar Teaching Hospital. And I'd like to also thank the entire team of this webinar. So far, it's been quite educative.
Thank you very much, Dr. Aguiye. Thank you. We thank you for your expertise and for bringing this expertise to us to help everyone learn more during Bloodless Medicine and Surgery Week. I'd like to highlight again what's been placed in the chat, and that is that we will take questions at the end of our next keynote speaker. But if you have any questions and for a particular speaker, please place them in the Q&A, and we will be discussing questions after the next speaker. So again, I'd like to thank Dr. Aguiye for an absolutely outstanding discussion of bloodless surgery in knee replacement. And again, thank you to the outstanding coordination of this conference, Dr. Nathaniel Osoro, and all of your colleagues and assistants that are making this work. So thank you very much. I think we can stop the screen share of Dr. Aguiye and move on to our next speaker, who is our keynote speaker. And that is Dr. Guimei Tan. And her topic is going to be blood salvage in bloodless orthopedic surgery. Dr. Guimei Tan is professor of clinical anesthesiology and pediatric anesthesiology, and she is the medical director of the anesthesiology preoperative clinic at Children's Hospital of Colorado, Anschutz Medical Campus in Aurora, Colorado, United States. Dr. Tan completed her graduate studies at the National University of Singapore, Yong Lu Lin School of Medicine, and she continued her postgraduate studies in anesthesiology at the National University Hospital. She also did a pediatric anesthesiology fellowship year at the Children's Hospital at Denver, Colorado, where she is currently professor of clinical practice in anesthesiology and a practicing pediatric anesthesiologist at the Children's Hospital of Colorado. She there is the chair of the Hospital Blood Utilization Review Team, and she's the co-chair of the Patient Blood Management Committee, as well as a current member of the ASA Patient Blood Management Committee. She also serves as the medical director of Pediatric Anesthesiology Pre-Optimization Clinic. Dr. Tan has an excellent working relationship with our transfusion medicine specialists and the blood bank. She has developed a hospital-wide program for transfusion thresholds and a massive transfusion protocol and the maximum surgical blood ordering schedule. And she is the go-to person at her hospital for patients and families for whom blood is not an option. She's also worked very closely with the Jehovah's Witness Hospital Liaison Committee members around Denver and in Colorado. Currently, she's working with the medical director of transfusion medicine to get her hospital, the Children's Hospital of Colorado, credentialed as a pediatric patient blood management hospital. Her passion is also in education, and she started her career in medical simulation. But what she's doing in education is remarkable, and we should all mimic this. Because transfusion medicine and patient blood management are not taught very well in medical school, at least in the United States, she has introduced a transfusion medicine elective rotation for the Pediatric Anesthesiology Fellows, where she integrates them into the blood bank and has them spend time so that they learn about the blood banking world and transfusion medicine from specialists in that discipline. She coordinates journal club activities and educational activities as well. She's also the director of the curriculum for the medical students, the fourth year, final year medical students at University of Colorado School of Medicine, in a curriculum that teaches patient blood management and transfusion on-call challenges. So for several years, Dr. Tan has been a member of the SABM, the Society for the Advancement of Patient Blood Management Annual Meeting Planning Committee. She continues to be. We hope that we will all see you at the SABM annual meeting in September 18th through 20th of this year in Minneapolis, Minnesota. She was the co-chair, Dr. Tan was the co-chair of the 2020 SABM annual meeting. She's thoroughly enjoyed her time with SABM and the ASA Patient Blood Management Committee, and she serves actively as moderator and speaker on many different sessions. So I'd like to now welcome Dr. Guinée Tan to talk with us about blood salvage in orthopedic surgery.
Thank you very much, Dr. Leseshock, for the introduction. And I am so honored to be invited to speak at this conference in the morning here, but I guess it's in the day or even at night at other hospitals and around the world. So my talk today is to talk about blood salvage in orthopedic surgery. And I understand that our previous speaker, Dr. Aguirre, mentioned that cell salvage is actually pretty limited in low resource countries. And I understand why, because of equipment issues, because it costs money. So this talk will be about blood salvage and how it can possibly help in patient blood management in orthopedic surgeries. So I have no disclosures for this talk, except that I am actually a pediatric anesthesiologist and I have not done adult surgeries for quite a bit. The objectives of today's talk includes trying to figure out and estimate what expected blood loss is for orthopedic surgeries, because it's important when we're going to use cell salvage, and determine how to use and optimize cell salvage in bloodless surgeries. And lastly, if we have to see if we can actually choose to use cell salvage in special circumstances, and we'll talk about that at the very end. Now, in our world, the population where we do bloodless surgery is usually patients who decline blood, who have rare antibodies that it's very hard to find allogeneic blood for them, or in places where allogeneic blood is actually not safe. We should do bloodless surgery in everybody, but in practice, that's not what's happening right now. So let's talk about how do we know how much blood is lost during different orthopedic surgeries. So I found this article. It's a 2025, so it's new and hot off the press article that has a marvelous table telling us what is the estimated mean of blood loss in the different types of surgeries. And if you look at it, you can see that it actually ranges quite a bit. For example, in primary total hip arthroplasty, it can range from 300 to 1,600 mils of blood loss. So, we have to take that into consideration. This article shows the top 20 most procedures associated with blood transfusion. And as you can see, femoral fracture, open femoral fracture ranks 5th, BKAs and above knee amputations 10th, and then spinal arthrodesis 14th. From other literature, I've found out that if you look at the risk of transfusions, orthopedic surgery does have a pretty high risk of needing allogeneic blood transfusions, even in children. So, what are the problems with allogeneic blood transfusions? I'm sure this audience know that it has some problems, not only just transfusion reactions, but Transfusions of allogeneic blood can lead to immunomodulation, which then can lead to infections, post-op hospital stay lengthening, and increase other morbidities and mortality. In terms of orthopedic-specific problems with allogeneic blood transfusions, so I'm going to say ABT. It's a very long sentence. As you can see, there are studies out there that speak specifically about hip fracture patients, spine surgery patients, and even joint arthroplasty that says and shows that it does have morbidity and mortality, including infections, length of stay, and venous thromboembolism if we do use allogeneic blood transfusions. So cell salvage is a tool. Just like the stethoscope, it helps us in delivering healthcare. However, it is only one tool out of a whole tool belt that we have for patient blood management. And hence, by itself, it probably is not enough to conduct bloodless surgery. Cell salvage is not a new idea. There's a marvelous article in 2019 that talks about the history of cell salvage. Just to show how old cell salvage the idea is, which is autologous transfusion, here's a quick timeline. So in 1818 and 1874, Dr. Blundell and Highmore from the UK, both are OBGYN doctors, thought about using autotransfusion. They wished they could take blood that was lost from their patients and put it back in them. They didn't do it. I don't think they did based on this article, but they thought about it. And then in 1883 and 1886, there was historical success in autotransfusion by Dr. Halstead in the US. He actually took salvage blood from a patient who came in with carbon monoxide poisoning. I didn't know we used cell salvage for that, but he did, and he survived. In 1886, Dr. Duncan was the first UK surgeon who successfully used cell salvage and autotransfusion in a knee amputation surgery. In 1914, autotransfusion idea was revived by Dr. Thies, who was a German gynecologist. He used it for, I believe, ectopic pregnancies, and his patients survived. The first cell salvage machine was actually invented by Dr. Griswold in 1943. So this one was I actually showed a picture previously of the first salvage machine. It looked pretty ancient looking. And then in 1982, Dr. Thurer and Hauer, I hope I'm not, butchering their names, mentioned in their article that orthopedic surgeries are actually ideal population for blood salvage, blood conservation. And the first modern cell salvage machine was invented or modified in 1975. So from this timeline, you know that cell salvage and autotransfusion is not a new idea. So why are we even using cell salvage? Why do we use patients' own blood compared to allogeneic blood? It has, compared to allogeneic blood, red blood cells from a salvage bag is actually more deformable. So they are more squishy, and they can actually go through microcirculation much better than allogeneic stored blood. It has also been shown that a salvage bag of blood has better amounts of 2,3-DPG compared to stored blood, and hence are able to release oxygen into peripheral tissues better when it transfuses. It also has no immunomodulation properties and no storage lesions. Now, using cell salvage needs some considerations. Number one, you need to plan for it. And like our previous speaker mentioned, you need special equipment. And last but not least, remember that when we return salvage blood, we are only returning red blood cells. The yellow products are all washed away. So let's talk about how cell salvage can reduce allogeneic blood transfusion. This is a 2019 article, which is a survey of Australian health system. They have a marvelous table in there that shows when cell salvage actually can reduce allogeneic blood transfusion. And I picked out those that were orthopedic specific. So it says that it is most beneficial if we can actually return 2 units of salvage blood per case. And these are the surgeries that they could do that. So removal of femoral nail, which I actually didn't know had that much blood loss, hip resurfacing, and then on open reduction of acetabular fractures. So those are the most beneficial in that hospital health system for using cell salvage. And you can see the rest of the orthopedic surgeries that you can use them, but maybe not as beneficial in terms of reducing allogeneic blood transfusion. Now, is cell salvage for every orthopedic surgery cases? It probably is not. We have to choose and pick what is going to be useful for or most useful for. This is a study in idiopathic scoliosis and for posterior spinal fusions. This study states that cell salvage is going to reduce allogeneic blood transfusion if you choose patients who are going to have more than 6 hours of surgery, whose corp angle is at least 55 degrees and has 12 level of vertebral fusions indicated, especially if we're going to do posterior column osteotomies in patients. So we kind of have to be picky on who to use cell salvage for to get all the advantages of it. I found a 2023 Cochrane Library study that actually showed very low evidence of using cell salvage in hip, knee, and other orthopedic surgery, but they did recommend using cell salvage in spine surgeries. So let's talk about cost. And I know in low-income resource countries, cost is a big deal. So cost is, before we talk about the cost of using cell salvage, I want to go back and talk about the cost of a bag of allogeneic blood. Now, if we cannot find blood for the patient, whether it's because of antibodies or whether because we just cannot find a bag of blood in our country, then the cost of allogeneic blood is priceless, right? We can't find it. However, in 2010, Dr. Schender et al. Did this study to find out what is the real cost of giving 1 bag of red blood cell. Now, a lot of hospitals would say the cost of a red blood cell is the cost that we pay to get the bag of blood, which is around US $200 to $300, depending on where we get the blood from. But based on activity-based costs, which includes the whole process of getting the bag of blood and then giving it to the patient, as you can see on this line graph, where it involves, the hospital consent, blood ordering, which takes time, processing from the laboratory, and then finally giving the blood using disposables and using, healthcare providers. So this was done in 2 US hospitals and 2 European hospitals. And they found that actually the activity-based cost of 1 unit of blood ranges from $500, and this is based on US dollars, $522 to $1,180. And that was done in 2010. I went into a Google calculator and did the inflation for 20 till 2025. So in this year, 2025, based on inflation, the activity-based cost of 1 unit of blood would be about 800 to 1,800. And this is another study by Odak and et al. That actually studied in a different way, and they talked about cost avoidance of using cell salvage in pelvic trauma surgery. And they found that if they used cell salvage, there was a cost avoidance of 86 pounds. Obviously, this is a UK study, and it was done by the Foundation Trust per person. I converted it to US, and that was $134 in 2013. Again, using the inflation calculator, in 2025, it would be about $184 per person if they use cell salvage. Yet another study by Bixby et al. In 2013 and said that using cell salvage was actually cost effective in repairing acetabular fracture, open reduction. In 2013, and this is closer to what I do, which is pediatric surgeries and cell salvage. This is a very general paper, but when you look at it, about 90% of this paper data comes from orthopedic surgeries. And they've shown that if we use allogeneic blood transfusion alone, it is actually more expensive than using cell salvage and autologous blood. Autologous blood here involves pre-donation, which actually is pretty expensive. And both of this is actually more expensive than using cell salvage and allogeneic blood. So it does have some cost savings. So when do we use cell salvage? When I talk about cell salvage, I always think about intraoperative usage, which I think is what most people, most hospitals around the world are using it for. However, there are some studies out there that uses cell salvage post-operatively. And I've highlighted some here that talks about cell salvage post-operatively having still some benefits in reducing allogeneic blood transfusion. For example, in hip and knee replacement surgeries, spine surgeries, and the cell salvage at the ICU article actually concentrate mostly on cardiac patients, but they also found some cost benefits in using that. The last article is actually from Italy. It's the Italian regulatory guidelines that was published in 2017. In that article and that publication, they actually said that if you expect the patient to lose more than 10% of their blood volume post-operatively, you can actually salvage that blood. Recommend salvaging that blood, putting them through a wash, and giving it back to the patient. So then, remember I said that cell salvage is only one tool out of the whole tool bag to help for bloodless surgery. But how can we better optimize that tool? So we need written guidelines. We need to actually boost the hemoglobin preoperatively. As for the surgeon section, we need meticulous draping because we don't want the blood, to be flowing onto the floor because then we can salvage them. We have to be meticulous about how we suction them, how to choose the bowls, the different bowls that the cell salvage has. And also, don't forget, if we use sponges and gauze to mop up bleeding, then those can be placed in normal saline wash in a little bowl, and then salvage, and then suction into the salvage containers. So don't forget about those sponges and gauze. So as for written guidelines, what's important is it has to be known, specific to your hospital, what surgeries would be useful for using cell salvage. So you're going to have to identify your surgeries and write it down there, because then, it will be automatically in the room, in the operating room for these surgeries. When I talked about machine bowls, different cell salvage machines and companies have different size bowls for collection. So they range from 200 to all the way down to 50 mil, 75 mil bowls. The difference in using the bowls is how fast or how soon blood can be salvaged in the machine and given back to the patient. So knowing your patient population, usually based on weight and size of patient, you would choose different types of bowls. Last but not least, there should be some suction guidelines in the written protocols based on how much pressure you can use to suck the blood from the surgery field. Because the above, from my research, above 150 millimeters mercury, we're going to cause a lot of hemolysis, and hence hemolyzed blood, red blood cells, cannot be returned back to the patient, and hence they're kind of wasting the salvage blood. So suction guidelines would determine and recommend lower pressures for suctioning. And also to avoid skimming in terms of suctioning. Skimming means you suction little red blood cells on the field itself instead of suctioning like bigger pools of blood, because that causes hemolysis too. Now, remember I talked about pre-op hemoglobin boosting. This article by McDonald in 2022 talking about efficacy of red cell salvage system, noticed that in their population, when the hemoglobin is less than 10.5 milligrams per deciliter, they were not able to give blood back to the patient because the salvage blood was too dilute. So how do we boost hemoglobin? And I know in this conference we have talked about pre-op hemoglobin boosting, but I want to repeat and kind of tell you that number one, we need to know what the blood loss is going to be for this particular surgery ahead of time. And we need to plan early, because if we want to boost a patient's hemoglobin, we need, several weeks ahead of time to get it to the correct number. And we need to do calculations. So knowing the blood loss and the pre-op hemoglobin a month ahead of time, we can actually use a novel formula, and this was by Cruz et al. Published in 2023. What they did was they used the maximum allowable blood loss formula, and they moved it around to find out what is the hemoglobin. If we want a hemoglobin pre-op to be, say, 14, how much how much do we have to boost in terms to have a post-op hemoglobin of, say, 8? So let me show you their graph. Oops. Okay, so this is the graph from the article, and this formula is based on knowing what is the estimated blood loss, as you can see from the different colors, what is the patient's weight, and in order to get to the post-op hemoglobin after the surgery, how high do we need to boost the hemoglobin to preoperatively? So for example, if your patient is, say, 70 kilograms, and you think your surgery is going to lose 2,000 mils of blood, then the patient's hemoglobin would need to be about 13 preoperatively. And that's something we will have to aim for to maximize the use of cell salvage. So I'm going to skip and go to special circumstances where we can possibly use cell salvage. When we have patients who, for example, decline blood or actually can't find blood for them. Even in cancer surgeries, there are studies using cell salvage and reinfusion of the salvaged blood to the patient. Now, why, it's a relative contraindication for cell salvage cancer surgeries are because we feel and we are scared, right? Because we are afraid of sucking tumor cells into the salvage container, washing it, and then returning tumor cells to the patients because there's possibility of recurrence and metastasis, which then may lead to worse mortality. However, it has been shown that giving allogeneic blood also increases relapse and death in cancer surgeries. So, salvage blood and allogeneic blood has the same potential for problems. I found this very old article in 1975 that probably made all of us really scared about reinfusing washed blood back to patients. So this was an article by Yao that was published in JAMA. It's a case report. He talked about an adult patient who came in with pulmonary hemorrhage because of lung cancer. And then he described the surgery that was done for the patient, and there was actually autotransfusion or cell salvage capability during surgery. And what they did was they took samples of the salvaged bag and found that, yes, they found tumor cells under the microscope. And then at the end, he said that this patient died. If you really read through the article, the patient, yes, the patient did die, but died from natural progress from his lung cancer. And if you read further, even though they found tumor cells in the salvage blood, they actually did not reinfuse the salvage bag of blood to the patient. So it was not even associated with the transfusion of salvage blood. But this is probably the first study that actually found tumor cells in salvage blood. Okay, so Fritsch in 2022 did a meta-analysis about cell salvage in cancer surgeries. And you see there are multiple studies looking into should we even reinfuse salvage blood in patients with cancer. And looking at the forest plot, it actually shows favors intraoperative cell salvage for recurrence. And there is no difference whether we use cell salvage blood or allogeneic blood or pre-donated blood when it comes to mortality, which is the right graph. So it seems that cell salvage blood could even reduce recurrence and makes no difference in mortality. This is a study on metastatic spine tumor surgeries, looking to see how viable it is to use cell salvage and how safe it is in this type of surgeries. So what they did was they had 12 patients undergoing spine tumor surgeries. During surgery, they took, if you look at it, stage A, they took 5 ml of blood from the patient at the beginning of before surgery, 5 ml when surgery was at its most manipulation from the patient. At the same time, they also took 5 ml of blood from the operative field while they're manipulating the tumor. Then blood was salvaged and put through the machine. They took 5 ml of the salvage processed blood, and then they put it through a leukodepletion filter and took 5 mils of that final product. And then they cultured it and looked for tumor cell clusters in those 5 mils of collected blood. So out of the 12 patients, so this is a pretty small study, they found positive tumor clusters in 3 of the patients whose blood was taken during induction of anesthesia and during maximum manipulation. So yes, they did find tumor cells in the patient's blood, but they only found 1 patient that had positive tumor cells when they collected the blood from the operative field itself. So it kind of shows that, yes, tumor cells are circulating in patients all the time, but it did not really, it may not always transfer into the blood that is lost during surgery. But what's more interesting is that after they put it through the cell salvage machine and through the leukodepletion filter, they found 0 tumor clusters, which kind of shows us that, the cell salvage machine and the leukocyte depletion filters are pretty good at reducing tumor cells. This is another study for musculoskeletal sarcoma and using cell salvage. This looked to me, when I read it, like life-saving surgeries, because they are doing hemipelvectomies, lower limb endoprosthesis surgeries for sarcomas, and white excision surgeries. And they did the same thing. They took surgical procedure involving cell savers. They took the leukocyte depletion filter at the end of the case and cultured it and looked for cytology on the slides. They also took blood samples from the processed bag that was going to be reinfused into the patient and smeared it on cells and looked for tumor cells. What did they find though? They found 0 cell cytology and tumor cells in both those blood samples. So that's what I found about reinfusing salvage blood back to patients for cancer surgeries. Let's go to the other circumstance, which is contaminated surgeries. This is a study by Hinson in 2020, where they used cell salvage system, and this is an ex vivo study using dog canine whole blood. They put cultures of bacteria into the canine blood, cultivated it, and then went through a cell salvage machine, and they put it through 2 leukocyte depletion filters, G and I. They took samples of blood along the way. What they found at the end is that right after cell salvage and washing, the bacterial culture present had reduction of 85 to almost 94% of the bacteria cells right after cell salvage. Now, once you put it through the first leukodepletion filter, it already filtered out 99 to 100% of the bacteria cells. And then after a second leukodepletion filter, 100% of the bacteria was not found in the final product. So it shows that cell salvage by itself does reduce bacteria cells, but if you put them through leukodepletion filters after that, it does a much better job. In 2020, Lilliston and et al. Did another study about using cell salvage in trauma laparotomies, whether it increases complications. So the population was patients that used cell salvage during trauma surgeries versus those that did not. And they found no difference in mortality and morbidity between those two groups. But I feel like what's more important is that both groups had antibiotics prophylaxis used, and thus maybe it's the important part about reinfusing cell salvage blood in contaminated surgeries is that antibiotics is actually very important in mitigating sepsis and propagation of bacteria. This study is also interesting in that they use cell salvage machine, but they did not mention filtering them through leukodepleted filters. So as far as I know, they did not use leukodepletion filter, just salvage blood plus antibiotics, and found no difference in morbidity and mortality. I want to introduce you to a review by Dr. Waters that was done in 2021 about cell salvage in trauma. And these are his key points: that you underutilize cell salvage during traumatic hemorrhage, and that it should be used more often. Now, I'm going to finish up by looking at the different societies and what they say about cell salvage. So I've kind of tableized them. So I have the European Committee on Blood Transfusions that says that in oncology and contaminated surgeries, yes, we can use cell salvage with consent from patients. However, the European Committee did say that in oncology, we should use cell salvage and then irradiate that salvage blood. The other societies includes the ones from Great Britain and Ireland, the SIMT, which is from Italy, Australia, NIH, and then last but not least, the American Society of Anesthesiologists that actually has no recommendations of using cell salvage for oncology and contaminated cases. So there are some guidance, and a lot of them mention that, you have to get blood consent and informed consent from patients when we want to do this. So what's the take-home points? Cell salvage is useful for bloodless orthopedic surgeries, especially if you choose the correct population and the correct surgery. And again, it is not the only tool in the tool belt. You have to optimize its use and use other pillars of patient blood management. One of the things that we have to remember to use cell salvage is we actually have to plan ahead. We need time. It's not something that, we should do like, oh, look, tomorrow I have a spine surgery. Let's push this machine in the room and use it. It's something that needs to be planned ahead and written in the hospital protocol. This is a code that we should, stop talking about it and maybe start doing. So thank you so much for inviting me to this lecture.
Thank you, Dr. Tan. That was very comprehensive and very informative for all of us taking care of adult and pediatric patients who may require cell salvage as one of their therapies. So thank you very much. We'd like to move on now. And I see that there are a few questions that have been placed in the Q&A, and I would encourage anyone else with questions to please place them in the Q&A, and we will try to get to all of them. I would also like to invite our panelists to contribute any of the answers to these questions if you would like and you have the specific expertise. So what I'd like to do is go back to the first question, and that was a question for That was for Dr. Aguayi for our first talk on knee replacement surgery. And Dr. Aguayi, you're still here. I see you. The question is, please can I know from Dr. Aguayi, can a knee joint replacement be done without the use of artificial materials to set it up, especially for an individual suffering from osteoarthritis? Dr. Aguayi, are you available to respond to this? If not, you'll have to unmute. But if not, what we will do is we will type the answer into the Q&A, which there is an option for. Okay, I think for that, we will have to type an answer into that question. Dr. Jadwin, do you want to, there are a few questions for Dr. Tan. Do you want to ask those? Perhaps they can be covered in one.
Sure. Dr. Tan, what % of blood is returned from cell salvage? I think you did cover that a little bit, but maybe clarify that again.
So I need to ask, I'm not sure what they're referring to, but usually cell salvage blood, if you lose, say, a liter of blood and you put that in a container and wash it, we would be able to return about half of it back to the patient. So about 50% can be returned to the patient.
Okay. And another question, could you please repeat your, Dr. Tan, please repeat your comment that accompanied the slide, boosting pre-op hemoglobin about not returning blood if hemoglobin lower than 10.5?
Correct. So I'm not suggesting not to return blood. It's just that it may not be as effective in reducing allogeneic blood transfusion. Because patients who start with a low hemoglobin, which means a low red blood cell mass, do not have the opportunity of optimizing the end product for cell salvage. Cell salvage mechanics is based on how much red blood cells is sucked into the container. So if you are already anemic, the amount of red blood cells that can be sucked in would be pretty low. And they may not be able to, number one, run the machine because they need a certain volume and red blood cell mass to run the machine. And number two, if you are able to run the machine, the end product may not have a high hematocrit. So usually a good salvage bag of blood has a hematocrit of about 60%. But if you start with low hemoglobin, they may not be able to get you up to a 60% hematocrit bag of blood. You may get a 30% bag of hematocrit, bag of blood. So I'm not saying not to salvage it, but I'm saying it's not going to be pretty optimized for returning of blood product. A lot of hospitals actually do a standby collection. And what that means is, depending on the surgery, they will suction the blood loss into a sterile container and then hold on to that container until the volume is optimized based on the machine bowl and the machine. And then they will open up the cell saver equipment and wash it through. They do this to reduce the cost of disposables for cell salvage. So for example, if you only are able to collect 300 mils from the patient, then most machines may not be able to salvage that. And you would save the cost of having to open and utilize the cell salvage machine. You're just gonna the cost would be the disposable of the sterile container. So it's less expensive.
And Dr. Tan, another question from Gary Koenig, who's a perfusionist I know. On cell salvage, do you regularly set up a first collect, only the reservoir and suction tubing to reduce the cost when using cell saver? We only open up the bowl set when we know we have enough lost blood to process and return.
Yep. And that is what's practiced in a lot of hospitals to save cost. You collect first, and then if you get enough volume, then you open up the rest of the disposables to wash through.
And another question, is there experience in the use of manual blood salvage from any of the panelists in Ghana? There is experience in use of manual blood salvage for clean, pooled, uncontaminated blood in a number of teaching hospitals.
So a lot of the articles I showed, some of the articles I showed in the post-op blood salvage modality, they actually salvage the blood from the drain. And not every one of them actually put them through a salvage machine. They do put them through a leukocyte depletion filter, but not a salvage machine. So that's the only time I see that. I've also seen an article from a low resource country where they collected blood from OB patients into a little container, and again salvaged it only through the leukocyte depletion filters, but not a cell salvage machine. So I'm not sure if that's what manual blood salvage is referring to. I would love to hear from anybody from Ghana.
Are there any of our panelists that have experience with this manual blood salvage from any countries around the world? Going to look around and see if anyone has their hand up.
Looks like Fred put up his hand. Could you put up your hand again, Fred? So if it's okay, we can enable Fred's microphone because he might have a contribution on that. And Professor Ilori also.
Thank you.
Yes, hello. Good afternoon. Thanks for the very fine presentations that have been made. So there is a lot of experience in the use of a manual blood salvage device from one company. So it involves the use of a filter and a manual salvage device that is handheld, not electronic or not electrical powered, that can be used in settings where there is no power. And it has a filter and accessories and a pump. The pump is reusable and the filters are disposable. So these are technologies that have been used, and a number of teaching hospitals in Ghana have that for mainly OBGYN, ruptured ectopic pregnancies, and some other settings. I know that one team in one of the teaching hospitals is considering the use of that for some form of vascular surgeries where they have blood that is pooled in the peritoneum and which is clean. All it needs is to have a good filtration system that prevents clots and other particulate matter from getting into the blood that is salvaged into the blood bag and reinfused right either intra-op or post-op. So these technologies are there, and it would be nice to probably explore how we can have some presentations on case study reports on the use of such devices in Ghana. Some 1 or 2 years ago, there was some presentation where one resident doctor presented on some few case studies in OBGYN setting. So probably I will be, maybe after this presentation, we can talk and I can find some of the obstetric gynecologists who are probably collating data on the use of this manual blood salvage device. It's called Hemafuse. It's from a US company and it's registered for use in Ghana and I think in Kenya. So these technologies are ones that can probably be explored. It wouldn't be ideal for all the settings. And the challenge that our presenter mentioned of having situations where you have to now discard the plasma portion with such devices, you collect the whole blood, you filter, you reinfuse. So all you have the whole blood The advantage, if you're able to use it, is that then all the clotting factors in the plasma and everything is given back to the patient. Oh, of course, there are limitations when you have situations where the blood could be contaminated, and there are relative contraindications and absolute contraindications. So I think that probably another opportunity, such technologies must probably be explained in greater detail with case study reports, and I'm willing and to make an effort to reach out to some of the clinicians who are using such devices so they can present case study reports for the benefit of the wider community.
Thank you very much. That's very interesting. May I ask you one more question about manual blood salvage? Who are the individuals that are allowed or privileged to be able to conduct this? Is it necessarily a physician or a technologist? Who is doing the manual blood salvage?
Yes, very good. It doesn't require highly skilled technicians and perfusionists to do. It requires basic training, so any of the theater team can use this device with the basic 2-hour, 3-hour training and practice. That's the beauty of such technologies, because in Africa, definitely there is a human resource challenge when you have automated devices in place. This doesn't have that challenge.
Thank you very much. I see we have a few more questions now. Is Dr. Aguayi available to answer? There's another question in the Q&A for you. The question is, in your workup, do you often check for malaria parasites or in fact give malaria prophylaxis to prevent unwanted depletion of the patient's hematocrit post-operatively in a malaria endemic environment?
I'm sorry, I haven't been able to reach Dr. Agwe. It looks like he's involved in an emergency right now.
Okay.
So we could still ask the question again, maybe tomorrow. So.
Okay. We will do that. Thank you. Thank you, Dr. Osoro. Here's another question.
Yeah. Professor Laurie has been having her hand up. She's a
Okay.
chairman of the College
Please.
of West African College of Surgeons, Anesthesia. So Professor Laurie, you can introduce yourself better. Speak.
Okay. Good afternoon, everyone. I'm Professor Laurie, a consultant anesthetist at the University of Calabar Teaching Hospital. I want to contribute a little bit concerning the manual blood survey. In most district hospitals, it's commonly used here in Nigeria, usually for ectopic pregnancy. And they use a very simple technique. They use a jug, a kit, maybe something like a kidney dish. They put about 6 to 7 layers of gauze in a funnel, and then they scoop the blood directly and put it inside that on the funnel to filter the blood. Then sometimes they add a little bit of anticoagulant to the receptacle, so that as the blood is being filtered, it's just physically looking. If there's some contamination, if there's blood clot, they through the sieve, the gauze sieve, and then they put it in a blood bag and transfuse it back to the patient. It has been done as far back as I can remember, since I was a medical student. That's the common method that has been used usually for ectopic pregnancy. And I've not seen it being used in any other state except in ectopic pregnancy, because usually when these women come, they are so bad, and there's the way to salvage them. And a lot of them do survive before they'll be able to get allogenic blood to transfuse them later on.
Yeah, that's the scoop and sieve technique, and we use it also in splenic ruptures.
Thank you for that information. It sounds like that is possibly the answer to the next question that Mindy Jackson asked. Is manual salvage being used at all in trauma? Anyone have experience with that? Dr. Laurie or Dr. Usoro?
Yeah, as I mentioned, it's splenic ruptures. If you're talking about, if we're talking about low resource settings, the scoop and sieve method that Professor Laurie described, we do use it for splenic ruptures. But of course, I don't know if the question was referring to a low resource setting. I didn't see the question.
It doesn't necessarily designate. It says, could manual salvage be used in the field? In the field for trauma. So when we think of splenic rupture, I'm thinking of in the hospital setting, but in the trauma.
Yeah, it can be used elsewhere, but of course, that scoop and sieve might not lend itself to maybe orthopedic surgery and all that, because you do need a body cavity where the blood collects, and then you scoop it, maybe with a gallipot or something, and then pour it. So it's in quotes, a bit crude, but it works. And none of the terrible fears people might have actually come to pass, like infection or some other problems. They simply, I mean, we don't experience it. The patients do very well afterwards.
Thank you. Very interesting. Okay. Do we have time, do you think, for one more question before we move on to the industry presentations?
Maybe one more.
There is one more question for Dr. Tan and for Dr. Pius. The training program, the training protocols are part of regular university curricular program, or is it done just at the hospitals in general? And have you ever had an infection post-transfusion case that that went to litigation? How would you deal with that?
I can tell you that my disclosure is that I have not used cell salvage in infectious case. So again, all this information is based on articles and journal review. But I can kind of give a suggestion on how to avoid, legal court case, because what's the most important thing about using cell salvage or any other technique for bloodless surgery in like cancer cases, contaminated cases, is the informed consent, right? We have to kind of go through a lot of risk benefits with patients before we actually want to use it on them, especially if the patient is a patient who declines blood, right? They don't really have any other choices to save their lives, except, getting all this special patient blood management choices. So the informed consent, I think, is key to try and prevent legal actions. Again, I have no personal experience.
Thank you. Thank you, Dr. Tan. Well, we do have one more presentation, which I'll introduce, and then after that, Dr. Jadwin will prepare us for the conference tomorrow. So what I would like to do is introduce, we have an industry presentation. And this next presentation is sponsored by HemoClear. It's from blood banks to bloodless care, national blood agencies as catalysts for transforming surgical blood transfusion practice. And this presentation is by Professor Sala Yuguda. And Dr. Sala Yuguda is Director General of the National Blood Service Agency in Nigeria. Please go ahead, Professor Sala Yuguda.
Thank you very much. Good afternoon or good morning to all the participants. So, like I've been introduced, I'm Sale Yeguda. I'm a hematologist by training and the Director General of the National Blood Service Agency of Nigeria. So, I intend to share our experience from Nigeria with respect to. Can you see my screen?
Yes,
Yes, we do.
but you need
Okay.
to put it on slideshow though.
Yeah, I'm on it.
Yes, now we see that.
Okay, so thank you very much. So I intend to share a little bit of our experience with piloting of cell salvage in Nigeria. So as the title goes, from blood banks to bloodless care, Nigerian National Blood Agency as catalyst of for transforming surgical blood transfusion practice in Nigeria. So a bit of disclosure, this, like you rightly said, this presentation is sponsored by Hemoclear, and it's a joint collaborative study between the National Blood Agency and Hemoclear, which is fully funded by FID. So let me just introduce you briefly to Nigerian National Blood Service Agency. The agency is an agency of the federal government of Nigeria, which is saddled with the responsibilities of ensuring availability of safe blood in Nigeria and at the same time regulating the practice of Nigeria. And one of our major challenges, like which most of the developing countries are insufficient blood availability. And this is mainly due to insufficient voluntary blood donors in the country, as is happening in most of the developing country. This, because of the scarcity of this precious commodity, and also the little that is available, most of it is being not appropriately used. So started with this information, there is also great interest in patient blood management and bloodless strategies in Nigeria. And this will help in bridging the gap between the non-availability of blood as well as the increasing needs, more especially in surgical patients in the country. So this is what led to the joint project whereby the agency, in collaboration with Hemoclear, got a grant from that is fully funded by FIT in order to deploy this technology, simple technology, into the country. So we, as the agency, like I said earlier, we are responsible for the coordination of blood transfusion service in the country and also ensuring safety, quality, and access to blood to everybody. And also, we are also responsible for increasing public awareness. So we do go around the country through public media, as well as sensitization blood donor drive to increase awareness about the needs for people to donate blood. And also we are also responsible for training and increasing awareness among the health personnel in order to manage this precious commodity in the country. So we now decided to integrate patient blood management strategies into our care in the country. And this has many advantages, among which is reduced demand for donor blood, which are not readily available, and it also increased the availability of our autologous blood in the country. So the leadership, like I said earlier, we have the national body, and we also have Nigeria is divided into 6 geopolitical zones. So each of the zones we have a zonal office. The other is a zonal center that is saddled with the responsibility of that particular zone. So, like I said earlier, we are bringing in this bloodless surgery in order to supplement and complement the scarcity of blood that we have in the country. So currently we are trying to review the national blood policy in order to incorporate patients' blood management system into the system. We're also engaging the community in order to increase awareness that this procedure is highly is available and is simple to use, and also can improve the availability of blood when they are in need. So as part of the program, we are also training the healthcare personnel on the use of the cell salvage autologous blood transfusion in the country. So this is just the picture of one of the cell salvage system that we are using, that was from HemoClear, whereby the blood is collected intra-op and is now being allowed to pass through this particular filter, where the blood is filtered, we collect the red cells separate, and then the debris can now be discarded. So once it's collected, it has so many advantages. A simple procedure and can be done by the bedside as intra-op. It requires no electricity, like one of the challenges that was discussed earlier, that non-availability of power in the country and most of the developing country. So this particular procedure requires no electricity, and it can also produce high quality blood that can be reinfused into the patient. So this is a schematic diagram of the system, where in the old system, that's the donor blood transfusion. You collect the blood and now discard it, that's intra-op, and now have to give the patient donor blood. But in this particular system, the blood is collected into the using the suction machine. So once it's collected, it now goes through this filter, and then it can now be reinfused into the patient. So this particular system has been shown to be very safe, cost-effective, and also scalable. And it can, like I said earlier, it can fill in the gap between the donor blood requirement. So once you use this one, you cannot just reinfuse the patient's blood that is already filtered and washed through the system. So like I said earlier, we are collaborating with HemoClear in a program to pilot this particular program in Nigeria. So currently we are piloting the program in University of Abuja Teaching Hospital and University of Calabar Teaching Hospital in Cross River State. So we are trying now to expand it to 3 more hospitals. We are targeting actually 150 procedures so that we see the performance of this particular cell salvage system in Nigeria. So, and it's also aimed at understanding the optimal method of autologous blood transfusion service implementation, and including the clinical and practical support requirement. Like I said earlier, we are also training the healthcare personnel on how to use this system. So even though we have not concluded the piloting, but it's interesting that we noted the early outcomes are very encouraging and interesting. There is a high acceptance by the medical personnel, and also we have strong cultural acceptance of the procedure. And also the clinicians are willing to work with this, and then early surgical outcomes are also has been discussed all through over the week. We know that the cell salvage is a very safe procedure that can be deployed to help the patients when more especially in major bleeding surgeries. There is need for autologous, for autologous blood transfusion use, highest more especially in obstetric emergencies. And also there is also reduction in donor blood usage. So like I said earlier, after this piloting, we are planning to, like I said, we are currently reviewing our national blood policy. So we are trying to integrate patient blood management system into the national blood policy so that it will align with our own the national regulatory frameworks. And also we have training programs that we are conducting currently. And also we are trying to see that we scale up this program across the country as a policy of the National Blood Agency. So thank you very much for listening. In conclusion, all I can say is that the government strategy and clinical care can be connected by policy-led implementation of our bloodless surgery strategies. And also global collaboration empowers national blood agencies to lead the change. Nigerian National Blood Agency Policy Innovation model for national implementation of cell salvage is replicable. So thank you very much for listening.
Well, thank you, Dr. Uguda, for a wonderful, informative presentation. I don't believe we have the second industry presentation that's going to happen. So
Are there
at
any
this,
questions? Any questions, please put them in the Q&A for Professor Yugoda. We'll give that a few seconds.
While we're waiting, I think Dr. Agwe just contacted me. I don't know if he's back on the meeting. Dr. Agwe, are you here? He was anxious to answer his questions. Well, if you're here, please unmute.
Well, while we're waiting to see if he will be
I am
able to
available.
join.
Yes, I am.
Oh,
Lost and found.
Oh,
So,
yes.
did you notice your questions? Because we want to take Professor Yuguda's questions if there are any, but you can meanwhile answer your own questions.
Are they on the chat?
No,
they're in the Q&A. I can
Q&A.
certainly read them
All right.
to you. There were two, I believe.
Okay.
One was, Dr. Adwiye, can a knee joint replacement be done without the use of artificial materials to set it up, especially for an individual suffering from osteoarthritis?
If they're referring to the prostheses, prostheses are artificial, and the trend now is metal and plastic. That has been for over 20 years. So yes, you can't do without artificial material for now. The trend is towards unicompartmental replacement. So if you have not the entire knee affected, but some portions of the joint, you could replace just those portions. That's the trend right now. Yeah, but in low resource settings, we still do the good old total knee replacement. So we don't do partial yet. But still, you have to use artificial material.
Thank you. Thank you. Yeah. There is another question, shifting gears a little bit, but very interesting for Dr. Adwiye. In your pre-op workup, do you often check for malaria parasites, or in fact give malaria prophylaxis to prevent an unwanted depletion of the patient's hematocrit postoperatively in a malaria endemic environment?
Well, no, it's not a standard protocol. We basically work with Paxil volume unless the patient has some symptoms that would be suggestive, because a lot of people would even be carriers of a certain level of the parasite load, which doesn't do any harm even to the hemoglobin status. Because we're in the endemic region, so basically a lot of people would be walking around with some level of the parasite in their bloodstream that doesn't do damage to. Yeah.
Very interesting. Wonderful. And there is one more question, although it's not sure I can elaborate on this one. It says the training of protocols are part of regular university curricular program, or is it done just at the hospitals in general, or even just in some hospitals?
Sorry, that isn't clear to me. The training of...
I think it was supposed to be training protocols. It looks like Marilia Afonso wants to know if the training protocols are part of regular university curriculum, maybe, or is it just something done in the hospital? Yeah, in surgery, I think it maybe the person is asking generally about exactly. Surgery? I think so. So we do have didactic lectures in my institution in bloodless surgery for the medical students, and also the residents do have some didactic lectures as well. So the bedside teaching, teaching in the OR, but yeah, it's part of the curriculum for us.
That's great.
Absolutely.
And it should be everywhere, right? Great. There is, I see in the chat, Dr. Tan put a question in the chat, which I spotted. So I will ask Professor Yugata, what you were describing with the microfiltration procedure, is that similar to what we were talking about as manual cell salvage, or is that different?
Yeah, I think it can be said to be manual, even though you don't collect the blood. I think what the anesthesiologist described earlier is like you collect the blood manually using a dish or something, and then go and wash it and retransfuse again. So I think that manual method doesn't include filtering and washing the cells. While this particular system, even though no machine that is required, but you need a simple suction machine. So to collect the blood, and then the entire system is closed. Once you, from the point of bleeding, so you just take it from there. Once you suction it, so it's outside, it's now closed system, where it will now pass through the filters, and then it will be washed there, and then another filter is also there in place to remove the to liquid deplete it and also remove the other debris, and then before you now transfuse it back. So I can say it's semi-manual or semi-auto. It's not actually automated. It doesn't require any high-tech system for it to be used.
Thank you very much. Great. Well, what I'd like to do now is let Dr. Jadwin introduce some of his study, and then we will wrap up and introduce tomorrow's program. Looks like you're still muted.
There we go. Thank you. Hopefully you can see my my slide. So I made a presentation last year, and we have sort of a call to action. We're seeking hospitals from outside the United States to contribute to this study. This is a study we just submitted for publication. I talked about this last year, but it's over gold discharge hemoglobin following red blood cell transfusions. It's a 49 hospital study with analyses between 2016 and 2023. And we looked at about 284,000 patients and about over 900,000 units of blood. And the key point of this is that 62% of the patients received 1 or 2 units of blood. And what we've shown in past studies is that if a patient received 1 unit of blood, 90% of the time they didn't need that single unit of blood. And if they received 2 units of blood, 60% of the time they didn't need those 2 units of blood. So the purpose of this study is to carry this out, and I'll just show you 3 slides from our paper. This is the discharge hemoglobin for all patients who had RBCs, and you see the median discharge hemoglobin here is about 8 or higher. And in all of these curves, you see there's been very little change over the past several years. So what this is showing us, at least based on the discharge hemoglobin, that there's not much of an improvement in blood use. This is the graph for patients who just received 1 unit of blood or 2 units of blood. And this is the graph for patients that had more than 2 units of blood. So if we take discharge hemoglobin as 8 grams or higher as evidence of over transfusion, then we can see these curves for, again, these 4 groups, all RBCs 1, 2, and over 2. And I think we can see it, there hasn't been that much change in over transfusion. About 70 to 80% of patients, particularly looking at the 1 and 2 units. And this is just based on the discharge hemoglobin without looking to see if they could have gotten IV iron and cell salvage or other types of things. And then finally, if we use what we call transfusion adjusted hemoglobin of 7 grams or higher, that's where we subtract the hemoglobin they received from the red blood cells from the discharge hemoglobin. We can see about 40% of patients, just based on the discharge hemoglobin alone, probably would have had hemoglobin around 7. And for 1 and 2 units, you can see this. So the purpose of this study is to recruit hospitals in other countries to participate. in this, so we can do some comparison. And there's more to it than this, than I just showed with you, but I wanted to share with you again the results of this study and request that anyone that would be interested in having their hospital participate, please contact me. With that, I will go to our last little bit. I'd like to introduce our talks scheduled for tomorrow, which is Bloodless Medicine Day, which starts at 8 a.m. Eastern Time. First is the World Bloodless Surgery Day Lecture by Dr. Neil Bloomberg at the University of Rochester. His title is Patient's Blood, the Best Blood. And secondarily, there's a presentation by Sarah Walbolt, TBN blood nurse educator. And her talk is Heroes of Bloodless Surgery, Ron Lappin, MD. I did hear Dr. Lappin speak back in 1979. It was, I didn't remember his name at that time, but I certainly remember the lecture, and it was quite inspiring lecture. He presented a whole number of cases of patients who had been denied surgery for things like small breast lesions because the patient would not consent to a blood transfusion. And these oftentimes led to unfortunate delays where the breast cancer, as example, was very large, and yet he was able to remove this without blood. And it left an opinion on everyone that heard him speak that, we have to be more responsive to patient needs. And certainly it was pretty egregious that people would not perform surgery without, at that time, 46 years ago, would not perform surgery without the ability to give blood. So hopefully you'll join us tomorrow. With that, I want to thank you for participating today.
Thanks very much, Dr. Jadwin. I do hope that you get a lot of our international colleagues on this conference to participate in your study. That's really important information that we need to get out there. So I would say that the meeting for today has concluded, and we look forward to seeing everyone tomorrow at the same time, 8 o'clock Eastern Time in the morning, and for that exciting program that Dr. Jadwin just shared with us. Thanks, everyone. Have a good day or night.
Thank you so much, Linda. Thank you, everyone. Thank you, Dave. And